This morning we're hoping to cover ultrasound in relation to fertility. So really I try to divide it into three components. Basically, how do you evaluate patients? What do you need ultrasound monitoring for? And the value of ultrasound in terms of outcomes, assessing outcomes and assessing complication. So really before you start evaluation of the patients, there is three components. You want to check their uterus, you want to check their tubes, and you want to check their ovaries. For the uterus part, ultrasound is ideal because you have a 2D ultrasound and then a 3D ultrasound. And then if you put water or saline inside the uterus, you also could have a 2D sono or a 3D sono. Then when you come to the ovary, variety of pathologies as I show you, and then of course the tube, they could be closed either at their beginning, which is called proximal block, or at the end, which is called distal block. Very rarely you also have closure at the beginning or the end, which would be, like both ends of the tubes are blocked, typically with an infection more than with anything else. So if you look before the evaluation, before the patient start any kind of treatment, one of the important things that you rule out is uterine anomalies. And we covered uterine anomalies in a different grand round, and certainly they are very, very common. So this is one of the classic presentations that we get with fertility, whether the patients would have a septum or an arcuate uterus, and then sometimes other pathology like fibroids or polyps or scars. So the two Mullerian systems, as you know, join, and then when they join in the middle, the wall in between of them fall away, and when it falls away, the cavity becomes one cavity inside the uterus. So this is Mullerian, two ducts are unified together and make one cavity. But look at the X-ray, which is the basic clinical evaluation. X-rays are the first step. They are of very limited value. Like a century ago, X-rays was the only thing that are done. Today, really, ultrasound has almost completely replaced the X-rays. However, they have their values in different situations. But if you look at this patient, she has those two horns of the uterus. You cannot really tell if this is a bicornuate uterus or this is a septum inside the uterus. From the X-ray, you cannot tell. Radiologists go by different signs, so they measure the point where the tube joins in on the right side and the tube joins in the left side, and they put certain formulas. Among them, if this distance exceeds 10 centimeters, then it's bicornuate. In reality, that's totally wrong. I mean, when you hysteroscope and laparoscope the patients, there is no way that you can determine whether this has a septum versus a bicornuate by measuring that distance. They also measure that angle. So this angle, they say if the angle is beyond 120, then it is very likely that this is a bicornuate. Again, wrong. I mean, you can have an angle that is above 120, but still with that angle, you actually have a septum, not a bicornuate uterus as well. So those two X-rays that I'll show you this morning suggest to you that hysterosalpingogram is a useful test to start with, but by no means a complete test. And at some point I'll show you like a cartoon showing the different evaluations of the same patients with the discrepancies between one imaging and the other. So this is as far as X-ray. Again, this is an extreme form. Look at that. One side of the uterus is almost up to her right iliac crest, and then the left side is hanging above. This turned out at laparoscopy to be actually septate uterus, not a bicornuate uterus at all. So this was the X-ray. What about 3D ultrasound? 3D ultrasound has basically revolutionized the assessment of the uterus, and with very few exceptions, MRI has become obsolete in those situations. So in the past, we used to send those patients to MRI to determine if they have an arcuate or a septate or this. I think this is part of the 1990s, but now 3D ultrasound. So how do you look at that? Look at the outside. This is the myometrium, and the dense part is the endometrium. Look at the two ends of the dense part. This is where the cornea of the fallopian tube starts. So if you want to join those by a line, and then take the midpoint of that line and drop a vertical line here, that distance is what determines whether this patient has an arcuate uterus with a measurement of less than 10 millimeter or a septate uterus with a measurement of more than 10 millimeter. Among infertility specialists, there is a uniform agreement that septums should be removed. But there is no uniform agreement that an arcuate uterus should be treated. And many believe that it is very, very controversial. There isn't a single prospective randomized trial to determine whether an arcuate uterus resection results in a better outcome or not. But we've had a series of patients who had abnormalities in the fundus and failed to conceive by conventional treatments and assisted reproduction. And then when these were corrected hysteroscopically, the same patient conceived using the same intervention. So again, this is the classic example. The cornea is here, the cornea is there. You join your line, you drop the midpoint down here. Not even that, the line really is cathedral looking, is convex upwards. It is not really a flat line in reality. It depends, however, how much distension fluid you put. So if this patient you're doing X-ray and push more fluid, it will flatten up. Similarly with hysteroscopy, if you do hysteroscopy and use, for example, office hysteroscope, the amount of fluid that you inject is moderate or low, so it will appear more denting down. When you take to the OR, it goes up. Also, when you cut, you want to cut a little bit above that. In one of our series where I did a second look on many of those patients that I have resected their septum, in about 15% of them, I have undercut this section. In other words, when I looked back, it wasn't good enough. I should have done more. The problem is that if you keep coming more, you will come to a point where you will make a perforation at the fundus. If you make a perforation at the beginning of the case, it ruins the case because the fluid will leak and you cannot continue your hysteroscopy. But if you make a perforation at the end, it is really of no sequelae whatsoever. Again, this is a 3D, but this one is definitely an arcuate. So if you join the line there, take the midline, drop it here. This is less than 1 centimeter. So again, this is an arcuate uterus. This is a small septum showing you the typical, like rabbit horns appearance of a septum. And again, you determine that by looking at the top. And if the top is a straight line, is not a heart shape, it's really the outside that determines that, then you're fine. Even if it is minimally dented, as I will show you in a second. So this is also a septum. The septum dips down. There is the two sides inside there. And this is a small septum. But look at the top. The top is whether it determines whether this is a septum or this is a bicornuate uterus, not the inside here, because the inside will have the same. So again, if you're doing a C-section, for example, and most of those will have a breech presentation at the time of delivery, and at the time of the C-section, you're able to exteriorize the uterus after delivery of the baby and look at the fundus. If that, sometimes you see that one side is going like 10 centimeter, 8 centimeter, of course, at the time of delivery, it is much bigger. Those are more more likely to be bicornuate. But even then, you cannot say. You have to wait a few months and then reevaluate later. Again, this is a 3D of a small septum. In our opinion, this small septum should be resected hysteroscopically. There are many ways in how to technically do it, and all of them are successful. One is to just use a simple hysteroscopic scissors and cut. Second is to use the resectoscope, the stores. And then the third is to remove the tissue as well. The three are equally successful. Certainly, the resection using the scissors is good, and the resection using the stores is good. We have just actually compiled a series of 68 cases of resection of uterine septum, where we actually have divided them with the scissors, and then 5 of them we have also removed the tissue of the septum. Because although the surgery is called resection of the septum, resection implies that you've taken it out. Really, with the scissors, you do not take anything out. You're just simply putting water, putting the septum on a stretch, and then cutting in between those. Again, this is another septum dipping in the middle of the uterus, a third one here. But if you look at the top here, there is a small dent. So this is more of a bicornuate. Still, despite that it is more of a bicornuate, it could be tackled hysteroscopically because you can stop here. But then you have a very small margin of error. If you go beyond, you will definitely perforate the fundus, more likely in this case. Again, here to show you where to put the crosses. So the crosses, you would like to think that they are at the midpoint of the line that joins the two cornea, but it's really above that. So keep that in mind, that that's above it. And that makes a very big difference in the reporting itself on the ultrasound. So done with the 3D ultrasound, we move to the sonohysterogram, which is basically putting water or saline inside the uterus within the cavity. And this is a patient that had a septum. As soon as you fill, there is 2 cavities, one on each side of the septum here. Sonohysterogram is one of the most valuable techniques in terms of evaluation. This is just putting a catheter. You can use one of many catheters that are used. The catheter always has a balloon, which typically takes 1 cc of water or saline. And this is a perfect lining. You see the lining is a thin line. Similar to ultrasound, you see the lining shining as a white line as well there. If that lining collapses, you see a white and then black and then white line as well in the midline. This patient looked like she has a bad uterine mass here, so the mass extends from here. All this was menstrual blood. We waited 2 days later, and she had a repeat sonohysterogram, which was perfectly normal as well. If you want to check a lesion in the lower segment, then you have to deflate the balloon and pull it down. There are 3 views on the 3D ultrasound. So there is a coronal view, and with the coronal view, you're cutting like that. There is a horizontal view, and you're cutting like that. And then there is a sagittal view, you're cutting like that. When you put the 3 views together, you can determine whether the pathology you have is at the front, anterior, at the back, posterior, right or left. And this is very helpful if you're going to operate on that. If you're just going to report that these are fibroid uterus, then it doesn't matter. And this is a big difference as well between like radiology and gynecology. So for example, this is a coronal view. So coronal view is literally like that. You're slicing all the way from top to bottom here. So this is fundus, this is cervix, this is just the balloon. And you can see here that this patient has a fibroid here and has a polyp there. So this is the fibroid, this is the polyp. If this is her right and this is her left, then she has a right uterine wall fibroid and a left uterine wall fibroid. This is the only information you can derive from the coronal view. Look at the sagittal view. So sagittal view, the fundus now is on this side and the cervix is on that side, and this is your balloon that fills with saline or water. This is the anterior wall, the front towards the abdominal wall. This is the posterior wall, and she has what? She has a submucosal fibroid. So submucosal fibroid is classified into 3 degrees as far as inside. There is a type 0, basically a polyp hanging inside the uterus, which you can twist, you can do many things. There is a type 1, which is like this lady. That fibroid goes a bit into the wall. So when you resect it, you have to remove part of that wall. Type 2 is that when this part that is in the wall is going almost beyond half the thickness of the wall. The thickness of the wall varies tremendously. So you get a postmenopausal woman, that wall is almost as 1 centimeter thick. In a young woman, that could be more, maybe 2 or 2.5, but the fibroid will eat part of that wall. And part of the treatment is take the fibroid with it down. At least you need to make it flat so that there is no ridges there. And many times we remove lesions, and then I look again and found there is a ridge, so I go back and smoothen that edge. Because if you don't, it is a problem in terms of putting like catheters inside the uterus for transfers and all that stuff. Again, this is a horizontal. So horizontal means what? Cutting like that. So if the uterus is sitting like a pear here, and you chop it, so this is the uterus, this is the saline, and the fibroid is taking most of the wall. And here again to show you that the fibroid is extending into the wall. So it is forewarning that if the fibroid is extending into the wall, then you need to resect part of the wall. This is a retroverted uterus, which is very easy to do on, the best way is just to do it by manual exam. But it changes the configuration totally. If you look at this patient, all those polyps look like they are posterior wall. In reality, they are anterior wall, because the uterus is flipped backwards. So this is the sacrum of the patient, and the cervix is here. The fundus should be on this side. The fundus in this situation, is tilted backwards as well. This is one of the benefits of doing both sonohysterogram and ultrasound in the office. So this patient presents with abnormal bleeding. You do ultrasound, all you can see is thickened endometrium. That's the first report comes as thickened report. So if the patient has a clinical problem and you find a thickened endometrium, then polyps are one of the commonest things. Again, could be polyps, fibroids, or scar tissue. So we do Doppler, and this shows you a feeding vessel. Almost every polyp has a feeding vessel there, and that's why when you do a DNC, when you do a polypectomy, you get a minimal bleed from that point. But that is a polyp there, and that is the feeding vessel, and the feeding vessel is at the top with the Doppler there as well. This is a coronal view, and the coronal view here showing you the fibroid on this side and showing you the polyp on that side, and the fibroid is coming from the left wall, and the polyps are coming from the right wall of the uterus. Again, sonohysterogram. This is a sagittal view. So the fundus is where on this side, the cervix is there. This is the anterior wall showing you a type 2 fibroid. So that fibroid is literally in the wall of the uterus, and the polyp is inside, there as well. This cartoon puts you the four together. What do I mean by four together? So this lady comes in with some kind of abnormal bleeding. So you do ultrasound. All you can tell from the ultrasound is what? That her endometrium is thickened. Thickened above and beyond the usual. So of course this is age dependent. So for postmenopausal women you want it below 4 millimeter. For younger women it varies tremendously in the site. So with this thickened endometrium you want to do further evaluation. Should everything be available in the office, it's ideal to do a Doppler. It will show you the feeding vessel that I've shown you in the previous slide. And then if you do sono, the polyp is big enough that it left only a slim of fluid there, but the majority of the cavity. This is the same patient having an office hysteroscopy, showing you the polyp there and another small polyp there. You can even see those vessels. So really you can complete the full evaluation of the patients and the treatment depending on what you can do in the office as well. This unfortunate lady had breast cancer, and had endometrial cancer, and it looked like she has a cystic area and fluid and so on. This was not fluid, was not cystic area, was part of the degenerated part of her endometrial carcinoma. This lady had breast cancer and has been on tamoxifen. And tamoxifen is a bit of a problem because it's tricky. If the tamoxifen just causes endometrial hyperplasia, then you would pick it up with routine evaluations with hysteroscopy. The problem, there was a large breast cancer prevention trial almost 15 years ago in the US, in which there were over 10,000 patients that were given tamoxifen. And in those 10,000 plus patients in the US, 4 patients developed abnormal bleeding. When they evaluated them using hysteroscopy, the lining was perfect. So they took their hysteroscope, were very happy. The patient, a few months later, presented again the similar problems, so they looked again, and it was normal. And then eventually both of them got tired, so they said, okay, let's do a hysterectomy. So they do a hysterectomy, and the pathology reveals a uterine sarcoma. So one of the problems with tamoxifen, it is sub-endometrium. This is not in the endometrium. So when you put the hysteroscope in the office and you tell her, congratulations, everything looks good, it's 90% of the time okay, but in 10% of the time, the lesion is under the endometrium and will not be picked up by anything. I mean, until you get the pathology report saying there is a focus of sarcoma, and I'll come back to that in a minute. So I've covered with you here what fibroids and polyps using 2D sono. The third issue that you can find inside the uterus is scar tissue. So this lady was classic, that she had an early pregnancy, miscarriage, DNC, still bled, another DNC, comes back with amenorrhea. So what's your best guess? It's an Asherman syndrome. So Asherman syndrome means that the uterus walls are stuck. Simply, the uterine cavity is a very small cavity. If you think of it in terms of implantation, you have a uterus that is typically 3 inches. An inch of it is a cervix, leaves you with 4 or 5 centimeters at the top. 60% of your implantations happens at the front wall, and about 40% happen in the back wall of the. So all you have is about 4 centimeters. If part of that is stuck together, then you have lost all your revenue. You will have lost all what you have to implant. So look at this young lady. This is her regular ultrasound. This is the endometrial line on a horizontal section. It's a bit interrupted. You can't really read much into that. It's just a bit abnormal. You put saline here, and then that scar tissue distends from the front to the back, and you get a pocket on the right hand. So this is a classic appearance of an Asherman syndrome following a DNC. And the treatment for that is hysteroscopic resection. You go in, you distend, and you cut. We used to cut with scissors. It doesn't do a good job because it's not straight. It's different from a septum where you go with your scissors and just cut. And I'll show you at one time plenty of those videos, just we now are recording all of them, cutting. Whereas here, you need more than that. So you have really 2 options. You either resect it using a resectoscope, but the problem with that, it is a monopolar, so you would have to use glycine, which makes visibility worse, or you can remove the tissue as well. These are your 2 options for the Asherman syndrome. Again, this is another case of Asherman. This is the sagittal view. Your catheter is down here. You inject the fluid. This is the front wall. This is the back wall. And you can see scar going from the anterior to the posterior wall of the uterus. So this is Asherman syndrome. Again, another case of Asherman syndrome. It looks interrupted here, but you can't guess. I mean, you can suspect, but you can't tell. You put some saline here, and there is a pocket here, a pocket there, and these two parts close. And again, you go hysteroscopically and either remove the tissue or cut the tissue. But when you cut it, it will have to be a resection. It cannot be done with hysteroscopic scissors. The hysteroscopic scissors is excellent, but it's a straight instrument, and it's a very delicate instrument. This patient has double pathology, so of course this line is computer generated to show you that the fundus was a straight line. When you look here, what does she have? She has a uterine septum. So this is a sono, this is the balloon of your catheter, small polyp that is within normal, and then you look at one side, she also has a polyp. Where the patient actually did last Tuesday, she was referred from across the bay. She had 2 pregnancies on her own. She doesn't have any infertility. The first pregnancy she had, she miscarried spontaneously at 8 weeks. The second pregnancy, she had a missed AB, so they went in and did the DNC. The pathology came back showing no retained products of conception. They scanned her, they found the sac was still there. So a week later, they bring her back to a second DNC, and the pathology comes back, no retained products of conception, and then they do an ultrasound, and she still has the gestational sac inside. So they took her for a third time to the OR, each a week apart, and they got the ultrasound in the OR room. They found the sac, they pointed their suction towards the sac, and they got it out. They sent the patient. We did her last week, and I have a beautiful video. If your time allows today, I would love to show it to you. She has a big septum, not a septum like that. She has a big septum like that. It is not so deep, but it is so wide. So it left her with a small pocket here in which implantation. And remember, that septum is fibrous tissue, fibromuscular tissue. So if you even implant on it, which is unlikely, you will miscarry 100% because there is no blood coming there. So there is no trophoblastic invasion. There is no mechanism for implantation. So she had really a part of that cavity going here and that part of that going there, and the sac was totally there. We cut that. We cut it with the scissors, and then we removed the tissue as well. And I have a beautiful video again, if your time allows, showing you the beginning of the case. You go inside the cavity, you can't figure out where you are, and then at the end you have a beautiful pear-shaped pink cavity altogether. Classic patient, again, no infertility, but she have a recurrent pregnancy loss. God willing, next month we'll try and cover recurrent pregnancy loss in a nice way. But here again, you have the 3D view. So you have your coronal view, which is a favorable view, showing you that the lesion is on the left side. You have a sagittal view, and then you have a horizontal view. So basically, the 3 views together, the horizontal here, showing you that the lesion is coming from the back, and then the sagittal showing you that it's posterior wall. So here you can tell that this patient has a left posterior wall pathology. So again, when you go in, you don't miss it. And if you look at every report in which pathologies were picked out blind means like a DNC, like polypectomy, which we have all done for many years, 70 to 90% of the pathologies were missed. Not 70 to 90 were removed. 70 to 90% were missed. Means that the maximum detection rate that you can get, whether you're looking for cancer or looking for polyps or anything, is a maximum of 30%, and typically is around the 10% margin. So really, all of those you have to look. The problem is that 90% of gynecologists in the US would look with the hysteroscope, would take the hysteroscope out, thank the OR nurses, and then do a polypectomy as well. So really, you haven't added much. You just added to your mental impression or information, but then it's a blind. And then they end up looking at it. So you really want to remove under vision if you can. So this is the uterus, its evaluation. What about the ovary? The ovary quickly has lesions. Fortunately for us, they are easily discernible. And from our residents' point of view, really it's ideal if you're going to do those in your office that you just keep in your mind there is only 3 or 4 common things. Forget about the rare stuff, the weird stuff that we talked about. So this is an endometrioma. It looks mottled. It looks like a bad TV screen. This is an endometrioma. If you see that, this is, it cannot be something else. I mean, there is only one differential diagnosis. There is this endometrioma as well. 3D of endometriomas are nice. You can take a swipe and then cut it in many ways. Here, what I'm trying to show you is that the endometrioma ate up most of her ovary, left her with 3 follicles. So when you have 3 follicles, you have to counsel the patient on 2 things. Number one, that if you remove those endometriomas, her ovarian reserve, or what we call like ability to respond to fertility drugs will be low. Not because of anything you have done, but because simply this endometrioma over the years ate up the majority. So left her with 1, 2, 3 follicles, maybe 4. So a woman who are in her prime age has 3 follicles will not respond. That is just a matter of fact. You do not create what is not there. The second thing when you remove it also is that it's controversial what measurement is worth removing before IVF. So if it is less than 3 centimeters, like 1 to 2 centimeters, it is definitely not worth removing. Because if you remove it, there is no difference in the outcome. If you have a big endometrioma, you have to remove it because it could leak and hurt, it could get infected, and so on. But if you have a 1 centimeter endometrioma, it's a bad luck. This is an inverted mode on the GE software that shows you the endometrioma is black now, rather than the endometrioma was white in the previous one, and shows you each follicle like that. So this woman is very fortunate. Why fortunate? Because she has 16, 18 antral follicles. So what's an antral follicle? It's a follicle that has grown over 2 months before you started. So you bring her on day 2, day 3, and all that, to day 2 of menstrual cycle, and then you scan her, you found those areas. Those areas indeed have developed over 8 weeks. They didn't start on day 2. They have been there for 8 weeks. They reach a point where you can just see them with ultrasound. Typically, that is between 4 and 6 or 4 and 8 millimeters in diameter. So this is an antral follicle, a woman who's been fortunate enough to have a high antral follicle. So even if you remove her endometrioma, she will respond nicely. She will do well. Again, this is another endometrioma. A bit of detail that this area of the endometrioma looks different density, so they call it dishomogeneous. It really doesn't make a difference. I want your eye just to get used to the idea that this is what an endometrioma typically looks like. Look at this one. Does this look endometrioma? No, it is different. I really can't describe it, cannot explain it to you what is different. It has those speckled appearance. This is a classic dermoid. As a matter of fact, our sonographers here, and I give them really tremendous credit for that, have not missed one dermoid literally in the past 5 years. Like every time they put dermoid, that was a dermoid, we do it, and you cut. The tricky part with the dermoid is sometimes it's easy like that, it is under the surface, so you make one cut, it is sitting there. But many times it's just 1 centimeter deep in the ovary. So you cut in the ovary, you find nothing, you are checking your conscience. Should I keep cutting? Because if you cut more, you know there is thermal energy, so you damage those eggs sitting there, or stop. If you stop, most likely you will miss the dermoid. So you have to be relatively confident before going in that there is one to fish for before. So for example, if you happen to cut from this end, you've almost cut through 2 centimeters of ovary before you reach the dermoid, and then the rest of the classic appearance of the dermoid is the hair and the sebaceous material, and sometimes many of the other stuff that you read about, like having teeth or thyroid or GI, which are all pretty common. Those patients, we always use the bag with them, so you take the dermoid, you put it in a bag and bring it out with the bag. If you don't, it will mess up the area in between, and potentially could cause a different kind of subfertility problem. But this is, again, you have to train your eye that this is what a dermoid looks like. Because I'll show you 4 or 5, everything in gynecology spectrum, with very few exceptions, with luck. This area has this erect, it's not cancer, it does look like pseudopapillae. This is not, this is just a hemorrhagic cyst. Hemorrhagic cyst means the collapsed area where the egg was 2 weeks ago. That's simply what it means. And the treatment is nothing for that. Again, this is what in the past, in the 80s and so on, used to be described as luteinized and ruptured follicle. Luteinized and ruptured means that there was a follicle, it didn't pop the egg, but the progesterone went up. So you check her progesterone, it's normal. You see our ultrasound, the area didn't disappear. So they said 5% of the women simply have a problem in releasing the egg, in popping the egg out. So it's called LUF or Luff syndrome, really of very small significance. Again, a hemorrhagic cyst, when it bleeds inside, and the bleeding happens because of excessive prostaglandin at one point, so it bursts, then you have a little bit of blood inside, and the clot settles, so you have an interface between the liquid blood and the clot. So this is a hemorrhagic cyst. So I've shown you the endometrioma, the dermoid, the hemorrhagic cyst, and then look at that. This patient here, you will look at it, you want to say, well, this is an endometrial cyst, or this is some other pathology. This is an adenomyosis. So adenomyosis is what? Is an extension of the endometrial glands into the muscle wall of uterus. It's totally different disease from endometriosis. So endometriosis, you look in the pelvis with your laparoscope, you find nodules here and there and so on. Here there is nothing to do with endometriosis on external. So they call it endometriosis interna, one of the old names, but basically it's a cyst here. Many of those patients, actually there was one of the Canadian radiologists, he did the largest series in the world where he did them before surgery, imaging with different modalities, and then the hysterectomy specimen and puts them against you, showing you those. I mean, those patients are extremely symptomatic, typically menorrhagia, chronic pelvic pain. I mean, very, very symptomatic. Adenomyosis is a miserable situation. And again, one time I'll show you the videos, and I have them of excising those adenomyoma from within the uterus. So you remove the adenomyoma and still leave the uterus. Dr. Lewis.
Peter, back up just a minute. What is the residents need to listen to this? What's the treatment of choice for dermoid?
The treatment for choice for dermoid really is excision if there is an indication. So let's say
it's a big. I mean, let's say it's a nice sized derm. Let's say it's 7-8 centimeters. And she's having some pain. I mean, it needs to come out. How do you treat that? What do you do?
Historically, they were opened up until the early 80s. Okay. So they had a laparotomy, ovarian cystectomy, or wedge, but preferably ovarian cystectomy, opening the cortex, enucleating it, and repairing the ovaries. In the mid-80s, a guy called Paul Devroy in Belgium started to do it laparoscopically, and they almost like made him quit medicine because they considered it heretical, because classically this has what? Sebaceous material and hair. And whatever careful you are, that spills. So he went in and did it laparoscopically. This is in the mid-80s. I was actually a witness of this process. So they actually got mad at this. Was the Free University of Belgium in Brussels. So he was the first to remove those laparoscopic. And since then, we all removed them all laparoscopic. I mean, there is really very little place in opening up those patients.
Yeah, and so are you doing a total oophorectomy?
Never.
Okay.
Never.
And so let me ask you a question. What is the success rate of doing a cystectomy on patients, laparoscopy, using a laparoscope, or doing it open? What is the success rate? I
mean, open should be 100%. Laparoscopy should be close to that. The only problem is after, so say if I show this one here, the only problem is sometimes you get occasional oozing, so you start bleeding, and then at some point, one feels uncomfortable, so it ends up removed. But that is much less frequent here than with endometriomas. So if you look at dermoids, they bleed very little. If you look at endometriomas, as one of the other guys in Belgium says, the operation starts beautifully and ends disastrously. So you open the cortex, you take out the endometrium, it shells as beautiful as ever. Once you come to the base, it bleeds in the base, and that's coming from the hilar, and then you end up either cauterizing because you're so stressed, so you lose the ovary, and so. But the success rate should be 100%. I mean, frankly, we do them now robotically. So beyond even 100%, I mean, you cut the stuff, you cut it out, you can know if you want to cut with the scissors here or go out a millimeter or two, and so forth.
The reason why I pointed out is that I've seen 2 cases from 2 different patients that were done in this hospital. One of the physicians is in this room where they basically just put a clamp across it and took the ovary out. In young people, okay, and of course, 15% of the time they're bilateral, they'll recur on the other side.
Exactly.
So that is, if you do that and you go to Dallas, Texas, you will get to go back to Dallas, Texas. Everybody needs to listen to that. If there are attendees that are doing this, but I'm telling you, that is below the standard of care. Would you agree with that?
100%. Beyond 100%. I not only share that view, but certainly the dermoid, because they look ugly and big. So the first thing they say, do you have an ovarian mass? Which is classically has frankly been done by general surgeon, not gynecologist. I mean, they look at the ovary, it looks weird. So the first thing they do is gets 2 Kellys and ties a big knot there. But it's more common, frankly, in town on endometriomas. So most of the endometriomas are bilateral, exactly. You have a huge endometrioma on one side, 2 clamps, it's out in 5 minutes. The other one has a moderate size, a wedge resection, and then the patient is unfortunate to also have a cervical dysplasia, so he does a leap. So a patient is sent with 1 ovary removed, 3/4 of the other removed, and the stenotic cervix. The chances of IVF success in there, 5%. On a good day, 10%. So most of the guys, frankly, decline those patients. They tell them, either go for a surrogate or go for egg donor and don't bother. But this is the commonest thing. As a matter of fact, there is a whole paper in the American Journal in 2005 just addressing that issue on endometriosis, showing that aggressive, and I think we talked about that one time, that not planned, well-planned surgery for ovarian endometriosis results in a significantly lower outcome compared to well-planned surgeries. I mean, you get somebody that just, remove, and if you're not sure, remove less. There is another time to come back, or there is a loophole. For the dermoids, definitely removing the ovary is unacceptable. In a young woman, I mean, if the woman is older, fair enough. I mean, if the woman but older dermoids are very worrisome. I mean, if you find a dermoid in older woman, that's another story, I mean, even in terms of evaluation.
Well, say, and we've seen a couple of people that incidentally during pregnancy we find what looks to be dermoids, asymptomatic, 2 to 3 centimeters.
Right.
Should they be removed at some point postpartum?
I think postpartum is fair enough. Of course, during pregnancy, we all cherish your patients, so they don't touch them, But if she has, for example, a C-section, I think the dermoid could be removed in a C-section after you get the baby and close and irrigate and so forth.
Laparoscopically at 6 weeks or
exactly.
3 months, they should be removed.
3 months, definitely. I mean, big dermoids, no question. And similar with the endometriomas. The endometriomas' life has changed. I mean, like in the past, people used to go for like 8 millimeter, endometriomas. And then the group from Spain, actually, this author, Juan Garcia Velasco, did a study, showed that there is no difference. I mean, you have a 1 centimeter, but you have a big endometrioma. First, you can't have access to the follicle. Second, if you go through it, it literally messes up the lumen of the needle. So whatever you do, you basically mess up the next 5, 6 eggs. They look normal at the time, but later on they are abnormal. I mean, at the moment they look normal.
One thing I would mention is that sometimes the dermoids take up the entire ovary and you don't have any choice but to take.
Of course. Of course, yeah. No, of course. And there is everything else. And then technical things happen. I mean, you go in there and the ovary is stuck to her rectum on one side and the sigmoid on the other side and the back of the uterus. By the time you freed it, there is no ovary. I mean, Monday, actually morning, did a bilateral hydrosalpinx in a very young girl that is coming for IVF. Huge hydrosalpinx. One side, and first this was read by ultrasound as an ovarian cyst, but when we put a blue dye during the surgery, the dye distended the cyst, so it's obvious that it's fallopian tube, it's not cyst. But the tube coils, always remember, hydrosalpinx coils. The hydrosalpinx is never a sausage, it's straight. So it goes, once it coils like that, it takes the ovaries in one of those loops. It embraces that ovary. So whatever careful you are, the part of that ovary will come out, because unless your eye is 3D, and I'm doing it robotically. So I start, with the portion of the tube close to the uterus and just burn that and cut it and pose. And then lift it up and cut the mesosalpinx and pose, and then try to remove it in a series of sequential PK bites. At some point, the ovary will be entangled. I mean, there is never a tube ovarian complex that at the end time of surgery, the ovaries come to you nice and clean and the hydrosalpinx is there. That's at the beginning. That's just somebody who had a mild chlamydia. But most people have chlamydia, gonorrhea, and a few anaerobic bacteria. Once you have the three together, you have a higher chance of that. This is a simple cyst, so the treatment is nothing. Even if you find a simple cyst in an asymptomatic woman, the treatment is nothing. And why is nothing? Because really those women will have a cyst 2 or 3 times a year. So if every simple cyst that you find, you remove, then we'll be going for surgery 3 or 4 times a year. This is a hemorrhagic corpus luteum. It looks the most worrisome ultrasound. It looks like cancer. Has nothing to do with cancer. Just blood here. Again, endometrioma, and this is from Harvard Medical School. Let me show you some during IVF. So during IVF, and I know IVF might not be our common interest, but here is the uterus. The ovary here is behind the uterus. The ovary there is nice accessible. This is the vaginal wall. So you have access here within like 1 centimeter, but this is behind you. So you have to lift the uterus. Very uncomfortable situation. And one time it is not just positioned behind; it's stuck. So you lift the uterus, it moves with the uterus. You pull back, it comes back, and you lift, and so on. So you have to persuade it, is the word. So here is the ovarian endometrioma and follicles. You leave it till the end, because if you do it at the beginning, you have damaged all your follicles as well. Again, 3 follicles there, 1 follicle and 2 more. 5, 6 follicles there, nice response. So this is the moderate response, what they call now gentle stimulation with IVF rather than aggressive stimulation. Again, multiple follicles here, but the ovary is positioned behind the uterus. So this is a classic polycystic ovaries. Her ovaries are dangling down. abdominal transducer. Our new generation probably have not, but you see it in the amniocentesis, I'm sure. But we did that in the 80s. I mean, it was technically, extremely, shall I say, delicate. I mean, you have a transducer with one hand, typically your left hand, and with your right hand you go through the needle, you numb the anterior abdominal wall, you go through the anterior abdominal wall, anterior bladder wall, posterior bladder wall, then the ovary. And you ask the patient to keep still, and you're getting an egg by an egg. I mean, we did that for 2 years. So when transvaginal ultrasound was discovered, we went on our knees to thank the Lord that this happened. Yeah, transvaginal ultrasound has revolutionized medicine, as you all would agree. This is a classic appearance of the needle procedure. The needle procedure, we do that with in vitro fertilization as part of the routine. This is the way it looks after that, so this is not abnormal. It looks hemorrhagic corporality. So this is the classic appearance of the... So what is that? That is fluid and blood. Collecting the space that was in the follicle will not disappear. I mean, it will not vanish. So this is the classic appearance 2 hours after the procedure and for the next 2 days. If you also look after the procedure, there is a small amount of fluid there. That amount of fluid is normal because the follicles had fluid, and you cannot puncture it and every drop will come out. Of course, excessive fluid implies either bleeding or hyperstimulation syndrome, as I will show you in a minute. So I mentioned to you the hydrosalpinx, and this is for our residents and for is a very important thing. There is never a hydrosalpinx that's rod like that. There is never one hydrosalpinx that is one, the end of the tube is closed here and this is a sausage. It coils around itself 2-3 times. So once it coils like that, you do the ultrasound, it has this C appearance. The C is not complete, so you don't have a full circle like a cyst. So it is tricky when they read it to you as a cyst and you go in as a hydrosalpinx. Why is it tricky? Because you need to counsel the patient before to tell them that if I find the hydrosalpinx, I need to remove your tubes. Very litigious in the real world, because if you remove the tubes on somebody who's 30 years old and then she has to go through in vitro fertilization, then she incurred an extra $10,000 cost because of you removing the tube. But if you left them, she also had no chance of pregnancy. On top of that, she has 100% chance that every month she will have pain in those tubes, recurrent infections, as you're all very familiar with, known as chronic PID. This is for embryo transfer. So this is a beautiful picture. The bladder is full, the uterus is straight. You put a catheter, it looks like a straight rod. This is when the gods are smiling on you. You just have a straight path like that. How many times does this happen? Not the majority of cases. So this one, the bladder is full. She doesn't have adhesions. So this one did not have a C-section. But look at that angle. So you go there with your catheter, it hits that and you come back. It hits that and you come back. So you want to put more fluid, but even with more fluid, because the measurement is that the fluid goes to the fundus. So first you push the bowel out, and then second, you straighten the uterus. So 2 purposes. It has to be moderate distension. Excessive distension adds no value. Little distension is not good enough. So what do I mean by little distension? When the bladder fills, this is the bladder fills till here and it keeps going out. And then this is another angle here. So with this angle, and again, beautiful pelvis, she doesn't have any adhesions, but look at that angle. So you put your catheter. So typically you want to put the whole catheter in, take the inside out, and then feed the other catheter through. And then this one probably had a previous C-section, so her uterus is stuck to her anterior abdominal. When she coughs, the uterus moves up and down. So that angle is there. Again, you have to put it in. Unfortunately, it is helped by traction, but we don't like traction because it releases prostaglandins and ends in a much higher expulsion rate of the embryos, even if you don't have any bleeding or anything like that. Look at this one, seemingly a straight shot. But when we put the catheter and take the picture, look at these curves. So having the curves inside is not good. If I detected it before and was lucky enough, then the treatment of that is hysteroscopic resection. You smoothen that part. You give her like cytotec before surgery, enough to do that, and then you go and eat that posterior wall, just enough. And all we're talking about here is a couple of 2-3 millimeters down, or 2-3 millimeters above. Again, similar curve, and it looks normal. So the uterus looks a straight shot, After IVF, really, this is where all your great help. So this is a monozygotic twin. One egg split into 2. Very bad obstetric outcome, as you all are aware. Quadruple pregnancies, not my patient. Excessive stimulation here. So this is a PCO. Once you see that, you start saying your prayers, because it means that you're going to have not just too many eggs, but also excessive response leading to hyperstimulation syndrome. A recent paper published actually this month, in April, or last month now, in April 2014 in the Infertility and Sterility, is a paper by a group from Duke University, whom actually I was part of the symposium and presentation 2 years ago at the ASRM. They looked at, if you increase the number of eggs, what is the increase in pregnancy rate? And if you increase the number of eggs, what is the increase in ovarian hyperstimulation syndrome? So basically, if you have from 1 to 5 eggs, you have the lower pregnancy rate and the lower chance of hyperstimulation. 5 to 10, higher pregnancy rate, higher chance of hyperstimulation. 10 to 15, highest pregnancy rate, higher hyperstimulation. If you go beyond 15 eggs, the pregnancy rate does not increase, stays exactly the same. So if you go 20, 25, 30, 35, 40, I mean to any number, you will still get the same pregnancy rate, but the hyperstimulation continues beyond. So the message is that 15 is your ceiling. In the US, this is totally different from Europe. I mean, in Europe, they tend to do gentle stimulation. In the US, they do most competitive stimulation, because the higher the chance, the higher your success rate. So you want to give, so you have a patient who is a moderate or high responder, and you give her excessive drugs. So this is a typical polycystic ovaries with excessive response. This is also excessive response during the stimulation. These two are both our patients, and both conceived and both had hyperstimulation. And then this actually from Harvard Medical School, from Dr. Levine there, and showing you the stuff. This is one of her patients who presented 3 months after that with severe right lower quadrant pain. And they wondered and wondered, and then at the end they did this ultrasound, and this shows you this appearance. Any guesses what is that? Shamik, you're the lady on the spot. You're the Iris. Guess what is that? 12 weeks severe right lower quadrant pain, doubled up bend, and then she goes to Harvard Medical School. They do an ultrasound and they find that. What is that? Just guess. I mean, no penalties. Yes. Yes, exactly. Ovarian torsion. So this is ovarian torsion, and it is mottled. And if you do Doppler, usually you get low blood flow. But yeah, exactly right. So even one day in REI and you're okay. So this one, severe pain also. This is a necrotic fibroid. This one is PID. So this is 3 weeks after her egg retrieval. So and she had also pain and fever and so on. So this is classic PID, and they put Doppler on it, and you can see that there is blood supply there. So this is what you call tubal ovarian complex. Not common, but typically it's seen in women who have previous pelvic infections. It's extremely uncommon to see it in somebody who comes with a clean pelvis. Because the way ART is practiced is different east and west, so most of the cases I've done, for example, in the east are for male infertility, so you never have problems. Because the women never had endometriosis PID, and not never. I mean, in the group of women who came because their husband had azoospermia or had oligoathenospermia, so you don't get this stuff. But if you start doing it for pure gynecological cases, you will get more issues, and also the pregnancy rate will be lower, because if you deal with endometriosis, your pregnancy rate is basically almost half. Almost half. I mean, take group for group, and you take a patient with the same age, same husband, same sperm, same everything. Her chances are 50% to have a sister who's sitting there and does not have endometriosis. Again, here is an appendicitis, acute pain, and she has appendicitis. It is, the treatment of that is straightforward. All the treatments of those is laparoscopic management, whether appendectomy or. Intradecidual sign, subchorionic hematoma, very, very common. The subchorionic hematoma, unfortunately, increases the odds of miscarriage. How much, nobody knows. What is the size, nobody knows. But certainly subchorionic hematoma is associated with a higher miscarriage rate. Many of them continues. If you look at women who bleed during pregnancies after ART, 15 to 35% will bleed in the first 12 weeks. In women who continue and deliver a normal baby at the end. Again, a molar pregnancy. So this woman was 11 weeks, presented with pain and bleeding, and it was a molar pregnancy. Lot of blood in the cul-de-sac. What's your guess? We want student on this one. What's your guess? So this woman comes doubled up with pain, have blood in the cul-de-sac. Or what looks like turbid fluid. The difference between blood and normal fluid is that the normal fluid is jet black, the blood is turbid. I mean, that's again, it's a guess. In the old days, we used to aspirate it. That's gone. Coldocentesis is gone. So what do you guess? She's bleeding, she's pregnant, she's in pain. Yeah, ectopic pregnancy. The patient, we scan her, and she has, this is her uterus, so she has here twins inside the uterus, and you look at the fallopian tube, she has an ectopic pregnancy. So this is a heterotopic pregnancy. So heterotopic means what? Means combined intrauterine and extrauterine. Under normal circumstances, the odds of that is 1 in 30,000. With IVF, the odds are 1%. So it moves from 1 in 30,000. Actually, 2 guys from Georgia, from MCG in a long time ago, published the incidence in natural pregnancy, a guy called DeVaux, and they reported that the incidence was 1 in 30,000. After IVF, we reported the first large series in 1991 of 17 consecutive heterotopic pregnancies following IVF, which is really rare. 17 patients had pregnancies inside and outside, and the incidence was approximately 1% of pregnant women. The treatment of that is not methotrexate. You agree? Why not methotrexate? Because she still has twins. So you can't give her methotrexate. The treatment is one of 2 things. If you have high intervention access to ultrasound, then you can do aspiration of aspiration of the sac if it's early, or even if the cardiac activity is there, you can inject potassium chloride. If you don't, then just do laparoscopy, clip it medial, burn it medial, so you would come here, just burn this part and stop, and then see if that decreases the bleeding, and then after that just take the mesosalpinx under it and so on. Problem is that uterus is very, very vascular, and I'm sure you scrubbed on many of the recent cases where they had interstitial, and you see how those patients are more likely to bleed and so on. So this patient also had an ectopic. We looked at her, and she had this area. So this was not the ectopic. This was a corpus hemorrhagicum. This was just her egg, and then the ectopic was here. Was that area here? So an ectopic pregnancy could be concealed as well. And again, ectopic pregnancy here, seen very nicely. The ectopic is where the crosses are. So this is the ovary, and this is the egg. So this is a corpus hemorrhagicum. Corpus hemorrhagicum is a normal finding after that. But here is the ectopic, and there is the sac there. Again, ectopic was the sac. And then finally, one of the complications is ovarian hyperstimulation syndrome. So in those 2 patients here, this patient actually is from Jerusalem, from Israel, from Dr. Schenker, one of the pioneers of ovarian hyperstimulation syndrome. This picture is one of the oldest pictures. This was published in a book in '95, but he really had that case from 40 years ago. The ovary, which you normally see, is like a lemon size, and then all the women is an almond size. So look at the size of those ovaries. These ovaries are 40 by 30 by 30 centimeters. So basically the ovary starts down there and fills up to her spleen and liver there. Also, these are corporal luteals. So you see the capsule is splitting on its own, is cracking and open. Unfortunately, it doesn't hold sutures. So it bleeds, you put your suture, after you put the nicest knot, it comes into your hand. And then another one comes into your hand, and so on. And this is from Cairo, Egypt, actually, the Professor Sarour, showing you again, putting the scalpel here to show you that the scalpel disappears in size in comparison to her ovary. So this was one of the patients referred to him at the Egyptian IVF ET Center with massive corporal lutea. Of course, most difficult to handle. The only option in those patients is not to touch, not to open. So when do you open? You open if she bleeds massively. If she bleeds slightly, you transfuse her. If she bleeds massively, you have to open. If she has a torsion that is excessive, so you're going to lose the ovary, so you have to do, if it is down still in the pelvis, if this is not up to here, then you do laparoscopy and detorsion. You do not remove the ovary. Or if you have an ectopic as well. So you're unlucky, you have hyperstimulation, you have ectopic. We had one of those actually in a physician, in a pathologist from Mississippi like 15 years ago. She had hyperstimulation. Her doctor was very happy over there that, here she is, IVF pregnant, hyperstimulated mildly. And then a week later he can start to see the sac. And then a week later she comes in doubled and he goes and does an ectopic. So ovarian hyperstimulation syndrome happens in anywhere from 1 to 3% of those patients. Pretty serious situation. And in those patients, you need to manage them by maintaining good fluid balance, by giving them anticoagulant like heparin or Lovenox, and finally by aspirating the fluid, either using an abdominal catheter like a pigtail catheter or a transvaginal aspiration as well. And I thank you so much for your time this morning. I know I've overload, but I think I still finished before time, so that's not bad. And any questions, if you have any questions for me. I thank you all very much and appreciate it. You have wonderful. Thank you, sir. All right, you're welcome. Thank you so much.
See you later. Oh, you should have asked. I didn't know how long it would take. No, this helps me with a schedule for you too. But what circumstances would you do a septum hysteroscopically only? And what circumstances are you going to do laparoscopic and hysteroscopic?
If you suspect any by cornea or any injury of the
So we would just do it both? Okay. Because I know we've got one coming up that you only said hysteroscopic on. And I can't remember who that is. It may have been.
She's doing better, yes, is that your goal?
It's got to be Danielle. Setting your phone. So I'm sorry, there's one more.
There is one, I think, Dr. Lewis, and thank you so much.
You're welcome.
The Dr. Lewis Center for Recurrent Pregnancy Loss and Understanding.
Amy. Amy Johnson, because she's been